topics is very much important because more or less every alternate student will get this specimen in practical exam. So the topics is not very large but very important for oral practical purpose. Though it is called pregnancy because it arises after fertilization, but there is no fetus and no placenta. But still, because it arises from the fertilized ovum, then it is called molar pregnancy. And this is trophoblastic proliferation. So this arises from the trophoblast. Trophoblast, you know, syncytial and cyto. So abnormal proliferation. Syncytial trophoblast is very much proliferative, but still more proliferation. Hyperplasia of both the cytotrophoblast and syncytial trophoblast. So it is a disease of the placenta. The placenta, instead of the chorionic tissue or trophoblast, is designed to form, take the form of placenta. Instead of taking the form of placenta, it is giving rise to mole-like structure, vesicle-like structure. And the incidence is 1 in 1,000, so it is in European country. In our country, it is more. It is about 1 in 400 or like that. So in Asian countries, the incidence is more in Asian population. But the disease, the molar pregnancy as such, is benign. Though it is proliferative, hyperplasia is there, but it is benign in nature, but there is malignant potential. It can turn into malignancy, so more or less 20% or like that, it can turn into malignancy. So that is the malignant potentiality is there. This is the picture. You see the mole, instead of forming placenta, this has taken the form of this. That is the vesicle-like structure, and this is the specimen, and this is the blood clot. So placenta, you see the retroplacental blood clot will be there. So macroscopically, this is the picture of molar pregnancy. Vesicles of varying sizes arranged in clusters or chains, areas of hemorrhage, which you see in the picture. That is, hemorrhage is there, vesicle is there, and areas of hemorrhages and fetal elements. Fetal elements is not there, neither placenta nor fetus, and that is complete molar pregnancy. So if there is no fetal elements, that means no amnion, no placenta, then that will be, or no fetal tissue, so that will be called complete mole. It's not written here, but that will be called complete mole. But partial mole, fetal elements will be there. So if you find fetal elements if you find any fetal elements here, amniotic sac or some fetal parts like head or limbs or like anything is there, or some very early stage dead fetus is there, then that will be called partial mole. So complete moles means no fetus, no placenta, and partial moles means the fetus will be there, fetal elements will be there. And along with that, because this is a proliferation, excessive proliferation of trophoblasts, both syncytial and cyto. We know that syncytial trophoblast produces human chorionic gonadotrophin. Because of the high human chorionic gonadotrophin, so that is the structure is like LH. So that stimulates the ovary to form the lutein cysts. That will be called theca lutein cysts in both the ovaries. Because of the high hCG level in ovary will show the presence of lutein cyst will be there in the ovaries. So high hCG release from trophoblast is the cause of lutein cysts. So molar pregnancy, we are getting the complete mole or partial mole. See, this is another picture of magnified view of the molar pregnancies. So areas of hemorrhages are there. This is the vesicles actually has transformed into this cyst-like structure. So varying sizes, cysts of varying sizes, and areas of bleeding is there. So this is a very large vesicle. We do not know whether that is a fetal amniotic sac or not. So that is to be decided later. That is picture of likely complete mole. On microscopy, there will be trophoblastic proliferation, definitely. This is the disease, that is the cause of the disease, proliferation of the trophoblast. Stroma becomes edematous and forming the vesicle. The stroma is vesicular and there is no absence of blood vessels. The vessels undergo degeneration, so absence of blood vessels. So no fetal RBC and no formation of capillaries or vessels. So first in the villi, so the villus capillaries are absent. So only the edematous tissue and proliferation, So villus structure is present, but as there is no blood vessels, still the structure, the finger-like projections like villus structure lined by syncytial cytoplasm. So that is you call the secondary villus. So tertiary villus when the blood vessels are present. So this is villus structure is present, meaning thereby it is not malignant. If it was a malignant, so villus structures would have absent. So cellular atypia not found. So that is the features of malignancy. So as it is a benign disease, the complete molar pregnancy is a benign disease, so cellular atypia will not be found. So histopathology by examination, you can say that is a benign disease, not a malignant one. So that is on microscopical examinations. So this is the microscopical picture. This is the edematous stroma and this is the form of villus, that is proliferation. So proliferation is there, much proliferation of syncytial cytoplasm of the villus and edematous stroma. So that is on microscopy. So why does this develop? What is the cause of transforming the villus chorionic tissue in the form of molar pregnancy instead of forming the placenta? So instead of forming the placenta, it is giving rise to the mole where there is no fetus, no placenta. So that the cause lies in the genetic. So fertilization by the sperm 23X. So usually the chromosomal structure or karyotype is 46XX, rarely 46XY, but usually 46XX. And that is fertilization by sperm 23X. So then why is 46? Duplication of paternal chromosome. So where goes the maternal 23X? That is either inactivated or that is not found. So because of the absence of 23X from maternal side, only paternal chromosome undergoes duplication, thereby giving rise to 23X into 2, so 46XX. So inactivation of maternal chromosome, likely possibility, maybe ovum may be empty because the chromosome is not found. So either of the two is the cause. So this is called androgenesis, 46XX, androgenesis from the paternal side. So that is the cause of complete mole. So complete mole is due to androgenesis. So fertilization by the 23X then undergoes duplication to cause 46XX, which give rise to no fetus, no placenta, but molar pregnancy. Or rarely it may be dispermy, 23X and another 23X. So usually fertilization of ovum after penetration by the sperm is prevented, but here the two sperm fertilize the ovum. So fertilization by two sperm, so 23x and another 23x, giving rise to dispermy. So either androgenesis means duplication or dispermy. So maternal chromosome by two sperm 46 XX. So both are coming from the paternal side. So if maternal chromosome is active, if the maternal chromosome is active, there will be triploid or 69. So this one is the partial mole. So if it is 69XXX or 69XXY means the two sperm 23X and 23Y is fertilizing another 23X, giving rise to 23X, 69XXX or XXY, triploid. If the chromosomal structure is triploid, it will not give rise to complete mole, but it will give rise to partial mole. So partial mole is, so by karyotyping only you can say, if the macroscopically you find the fetus is there, so in that case it is a partial mole. If you don't find any fetus, but still you on karyotyping, you can say it is not a complete mole, that is a partial mole. Why we are differentiating between complete mole and partial mole, that you will know later from the later slides. So both maternal and paternal chromosome are there. In case of 69XX or Y, both maternal and paternal chromosome is there. So staining with P57, that is a nucleoprotein which is transcripted from the paternal side but expressed on the in presence of maternal gene. If the maternal chromosome are not there, this P57 nucleoprotein will not be there. So by immunostaining, you can say that it is a partial mole or a complete mole. So staining with P57 is positive, and in case of partial mole, and amniotic sac and fetal parts macroscopically is absent, and or even in ultrasonography you can find this thing, and chance of malignancy is less than 5%. So in case of complete mole, chance of malignancy, as I mentioned, it is 20% or like that, more than that. But in case of partial mole, it is less than 5%. So very, very less. So if it is a partial mole, we are in a very safe side. Now this is the diagram. See maternal chromosome and this empty ovum. Duplication is giving rise to 46XX, so sheep cell duplication. And in case of dispermy, 23X and 23 this is give rise to 69XXY, triploid cells, maternal and fetal paternal chromosomes are there. So this is the cause or pathogenesis of the complete mole, and this is the partial mole. Then how does it come to us? How it is presented to the clinician, this molar pregnancy? So vesicular structures are there. So obviously, as there is no pregnancy, it is a disturbed abnormal pregnancy. So because of that, the uterus will try to expel the content. So thereby separation of the molar tissue, giving rise to bleeding. Amenorrhea, of course, was there because of pregnancy. So pregnancy test was positive, followed by bleeding PV. So one of the cause of the early pregnancy bleeding is molar pregnancy. Other two are, abortion and ectopic. So amenorrhea followed by bleeding PV, and pain abdomen definitely because uterus is contracting to expel the molar tissue, and morning sickness will be exerted because of the excessive trophoblastic proliferation. hCG level will be high, estrogen progesterone is also high, so that will be give rise to excessive morning sickness. So excessive morning sickness, other cause is twin. So another cause is molar pregnancy. So early onset preeclampsia before 20 weeks. Usually preeclampsia means pregnancy-induced hypertension appears after 20 weeks. But in case of molar pregnancy, so if you find the pregnancy-induced hypertension before 20 weeks, you can think of molar pregnancy. Likely you are dealing with molar pregnancy, which will be confirmed by the test, which will be stated in the later slides. So early onset preeclampsia. So exaggerated morning sickness and preeclampsia can be the presenting picture, and bleeding and amenorrhea followed by bleeding and pain is also a presentation. Sometimes with features of thyrotoxicosis, because hCG you can see you can see that hCG can stimulate the structure thyroid glands to cause, or hCG have the properties of TSH-like properties, so it can stimulate the thyroid gland to cause thyrotoxicosis. That can be the presentation. Suddenly a mother with pregnancy coming with thyrotoxic feature, so you can think of molar pregnancy. So thyrotrophin-like effect of, that is due to thyrotrophin-like effect of hCG. So these are the three or four types of clinical presentation in case of molar pregnancy. Then what are the signs? That is pallor. Because of the recurrent bleeding, amenorrhea followed by bleeding PV, irregular bleeding PV. So there will be pallor. BP may be high if there is pregnancy-induced hypertension is there, PET, preeclamptic toxemia is there, and uterus, because of the excessive proliferation of the molar tissue, uterus is bigger than the period of amenorrhea. Suppose it is 10 weeks amenorrhea and you are getting the pregnancy or uterus 12 weeks like that or 14 weeks like that. So that is because of excessive proliferation, uterus is bigger than the period of amenorrhea. Doughy fill, because there is no liquor, that is a firm elastic fill, only full of molar tissue, that is doughy fill, and no fetal heart sound, fetal parts. So that is applicable if the size of the uterus is 20 weeks or 24 weeks like that. So very much bigger uterus with the molar tissue. So in spite of that, you don't find any fetal heart sound or any fetal parts, even by ultrasound. Expulsion of vesicular mass. So by 10 or 12 weeks pregnancy, if you find bleeding and pain, and if you examination of the blood, if you find the vesicular mass, that is diagnostic. So molar tissue on the process of expulsion is the diagnostic of molar pregnancy. So what are the investigations you can go for the molar pregnancy? So no USG findings. Oh, this is the USG findings. You see, molar pregnancy, this is the cystic species, and this is the other proliferative tissue. So this can be confused with so many things. So we are coming to that later on. So USG, that is a snowstorm appearance. That is snowstorm appearance, echogenic mass with anechoic areas. So that is the cystic species. And no fetus, no amnion. No amniotic sac and no fetus. That means it is complete mole. If amniotic sac and fetus is found, along with that snowstorm appearance, that is will be partial mole, but it is the picture of complete mole. Excessive vascularity of the uterus on Doppler. So vascularity of the uterus will be very high because of the proliferation of the trophoblastic tissue. So by Doppler, you will get the increased vascularity of the uterus, and mass is lacking of vascularity. But uterus is very much vascular, but the mass within the uterus is avascular. Because of the absence of vessel, no vascularity. So that is by USG, you will get the picture. So in partial mole, you find the fetal parts and amniotic sac, and in invasive mole, the molar tissue penetrates myometria. So if it is an invasive mole, that is not benign. Invasive mole is locally malignant. That is So if this molar tissue invades the myometrium, so in that case, and it can penetrate the myometrium, reach the serous coat, so that is called invasive mole. So by USG you can see whether it is invasive mole or not, whether it is a partial mole or not, or whether it is a complete mole. That you can know by USG. So this is the USG which has already shown molar pregnancy USG. So you may be given this USG plate also to identify what is the diagnosis. So you come to the other investigations, serum beta hCG estimation. So which is very, very high, in case of molar pregnancy. And after 48 hours, not after 48 hours, actually at 48 hours or within 48 hours, if you estimate a beta hCG after evacuation, then that will act as a baseline hCG value to monitor whether at our subsequent estimation whether the hCG level is falling or rising. So one beta hCG estimation is to be done. So just after evacuation within 48 hours to know what is the baseline hCG. Then serial estimation for monitoring of the disease. Whether the disease was present which have been completely expelled or something is there, especially if penetrated the endometrium, penetrated the myometrium, that is invasive mole, so hCG level will not fall because molar tissue is remaining within the myometrium, that you cannot remove unless you do a hysterectomy. So in that case, hCG level will not fall. So 1 to 2 weekly monitoring of the beta hCG for monitoring of disease, that has to be estimation. Estimation should go on 1 to 2 weekly interval. X-ray chest, whether to see whether there is metastasis or not. So molar tissue can embolize, enter the vascular tree and can lodge into the lung, that is the embolization, or it may be from the beginning there was a malignancy which has been metastasized into the lung. So X-ray chest as a baseline investigation, X-ray chest is to be done. So if there is metastasis, if there is your invasion of the myometrium, so that indicates possibly you are dealing with the malignant case, not the benign one. And CT scan brain you can do if there is metastasis in the chest X-ray. So otherwise CT scan is not needed. So if chest metastasis, then you can go for CT scan or MRI of the brain. So investigation is other than USG, you are doing estimation of beta hCG, rather serial estimation, and X-ray chest to know is metastasis, and this is CT scan of the brain, whether to know are the other metastasis, other sites of metastasis. So what is the treatment? Definitely that molar tissue is having though benign but having malignant potential, and because it is presenting with bleeding and pain, so you have to evacuate the uterus. So that is done by suction evacuation and follow-up and monitoring whether the beta hCG is falling or not. So that is the treatment. And evacuation should be done irrespective of size of uterus. Suppose a mole of 34-week size, that means just below the diphisternum, still you have to go for evacuation. Definitely you see when you are evacuating the molar tissue, along with that lot of bleeding will occur. So giving the guard against the bleeding, so blood transfusion must be arranged. That is, be must. Without arranging the blood transfusion, one should not go for evacuation of the molar tissue, and he or she will land in a mess because the patient will collapse on the table and bleeding could not be stopped immediately so you may lose the patient. Blood grouping and X-ray chest is to be done. Blood grouping is for the blood, arranging blood transfusion. Other than that, an X-ray chest, I already mentioned for metastasis. Laminary tent, because for the evacuation, you need to dilate the cervix. If already on the process of expulsion, if it is dilated, 2 finger or like that, you may not have to dilate the cervix. But if it is not on the process of expulsion, only it is presented with the bleeding, then you have to dilate with the closed cervix. You have to dilate the cervix either with laminaria tent. Laminaria tent, you know, it has to be introduced at least 24 hours before the dilatation, assumed time of dilatation, or you can be dilated by the prostaglandin misoprostol 1, prostaglandin 1, misoprostol. So cervix has to be made dilatable either by laminaria tent or by prostaglandin. Then after dilatation, you have to introduce the suction cannula and oxytocin infusion. Oxytocin infusion will promote uterine contraction. So uterine contraction, if promoted, it will reduce the blood loss. So whenever you find there is much of bleeding, so in that case, if you start oxytocin infusion, there will be blood bleeding will be less. So it will reduce the bleeding. So blood loss will be less. So oxytocin infusion is a very important measure, especially during evacuation. So when you are evacuating the uterus, if the uterus does not contract, then there will be a lot of bleeding. So oxytocin infusion is a must. So arranged to blood transfusion is a must. And though if you give oxytocin infusion, because of the contraction of the uterus, the molar tissue may enter the circulation, and that is the risk of embolization. So there may be pulmonary metastasis. Pulmonary metastasis because of the oxytocin. So we only usually do not rely on oxytocin for expulsion, but we take the help of the oxytocin to reduce the blood loss during our suction evacuation procedure. So what about anti-D immunoglobulin? If the mother is Rh negative, whether to give anti-D immunoglobulin or not, definitely we have to give it, though complete mole is having no vessels, so no blood. So in that case you can avoid, but it is not possible to know whether you are dealing with a complete mole or partial mole. So better to administer anti-D immunoglobulin to prevent Rh immunization in case of Rh negative mother. So suction evacuation with the following points you have to remember. Then how to do the post-evacuation surveillance. After, what are the risks? What is the risk of molar pregnancy? Number one, definitely you have to say that it is a risk of malignancy, which is more than 20%. So because of the chance of malignancy, you have to monitor the woman by beta hCG estimation 1 to 2 weekly. Whether that is falling or plateauing or it is rising. So if it is not fall by more than 10% successive 3 weeks by serial estimation, then possibly it is turning into malignancy or invasive mole are there. So in that case, so you have to take measure to stop the growth of the molar tissue. So it is usually normal by 6 months. Usually by 14 weeks. So 12 to 14 weeks is the usual time for normalization of beta hCG. So that you cannot say without serial estimation. So that is the beta hCG estimation to be done 1 to 2 weekly intervals. So normal by 6 months. X-ray test for metastasis, of course, has to be done, especially at 3 months interval to know whether there is metastasis or not. Whenever there is failure to fall with hCG, so one of the possibilities is metastasis in the chest. Ultrasonography to detect remnants of molar tissue. So after you have evacuated the uterus by suction evacuation, still it may not be possible to evacuate all the tissues. But the uterus is very much soft. You must be very much cautious. If you undergo over enthusiastic curettage, you may perforate the uterus. Because of that, some of the molar tissue may be remain in there. So ultrasonography to detect remnant of molar tissue. If there is failure of fall of beta hCG, you have to diagnose. And thecal lutein cyst, of course, in these cases, if the hCG level is high, then thecal lutein cyst will also persist. This is the lutein cyst, so depending on the beta hCG level, that does not require surgery, but that will be only tackled if you reduce the beta hCG level by some other drugs. That we are coming to that later on. So that is post-evacuation surveillance by beta hCG serial USG to detect molar tissue and thecal lutein cyst. So that indicates that it is not going to normal, and X-ray chest, of course, for metastasis. So if there is failure to fall, that is plateauing of beta hCG, or there is rise more than 10%. So baseline USG, baseline hCG we have already mentioned. So above the baseline, if it is 10% rise, that means there is rise. And if there is less than 10% fall, for subsequent estimation of beta hCG, that means it is plateauing. So these are the two indications for starting the chemotherapy or drugs to reduce the beta hCG level. So not, or if there is failure to normalize after 6 months. Whatever may be the level, whatever low level may persist, if it is not normal after 6 months, then there is an indication that something is wrong, so you have to start chemotherapy. And in that case, it will be called gestational trophoblastic neoplasia. So whenever it does not fall normal by 6 months, it will be called, or if it is rising, it will be called gestational trophoblastic neoplasia. So it was molar pregnancy, so then it will be, which was benign in nature, but gestational trophoblastic neoplasia is not a benign. It is malignancy, and so diagnosis will be changed. So change of diagnosis. So what about the prognosis? Already mentioned, there is benign disease, but 20% chance of malignancy. So because if it normalizes within 6 months, so conception you can allow by 6 months after normalization. OCP, after normalization of hCG, OCP you can prescribe to prevent pregnancy by up to 6 months, because if you do not give any contraception, the pregnancy may occur, the woman may conceive, giving rise to false impression that possibly the molar tissue is persisting or GTN is there. But so OCP is to be prescribed, and always whenever the beta hCG is going high, so chance of conception as it is there, so pregnancy USG to be done to see whether the pregnancy is there or not. Risk of recurrence is 0.9%. So if it was a molar pregnancy, at the next pregnancy, chance of recurrence is 0.9, not less than 1%, that means. Risk of choriocarcinoma, we have repeatedly mentioned that it is 20%. So outcome of pregnancy, but if she conceives after 6 months of normalization, So that pregnancy will be undisturbed. There is no chance of teratogenesis, of no chance of abortion. So outcome of pregnancy is normal. So that is about the prognosis. Prognostic risk scoring. About few words about GTN, though we are not taking the GTN class, but very important to remember, if the age is more than 40, so this is the extremes of age group and chance of molar pregnancy is there. So when the risk is more than 40 age, that is a risk factor for developing GTN. hCG level, if it is very high, suppose 1 lakh or more, then chance of GTN is there. Then antecedent pregnancy, if it is molar or normal, so GTN may develop following molar pregnancy 20%, following normal pregnancy. If it is after normal pregnancy, it is almost, in all the cases it is GTN. But in case of molar pregnancy, only 20%. So interval from pregnancy, suppose if it is more than 4 months after normal pregnancy develops the high beta hCG level, not because of pregnancy, then the risk is GTN is more. And metastatic site and number, that is taken into account. If it is the lung, that is separate, but if it is in the brain or if it is in the liver, the risk is more. So previous chemotherapy, if somebody was given chemotherapy for the beta hCG level, so that is a risk factor, high risk for GTN, so more than equal to 7. So after scoring, if we find more than 7, that table will be there in the books. If the score is more than risk, so that is a high risk for GTN. So chemotherapy, you see, what chemotherapy you have to give to be given to reduce the beta hCG level, so that is methotrexate injection and leucovorin. Leucovorin is folinic acid. So methotrexate causes the folic acid inhibition. So in that case, so many side effects will be there because folic acid is very much needed for epithelial growth. There may be ulceration or like that. So leucovorin is to be given 1357, and 1357 is methotrexate and leucovorin will be 2468. So alternate day. So that is one chemotherapy. And injectio etoposide is another one, but it is more toxic. So always we give methotrexate. If it does not respond to methotrexate, then we can go for etoposide. Or if it is etoposide, especially if the score is more than equal to 7, or otherwise, that is a single agent chemotherapy. Single agent chemotherapy, either methotrexate or etoposide, and multiple agent when the score is more than 7. So score is less than 7, either methotrexate or etoposide, so that is to be given. But if his score is more than 7, then it is imaco. Imaco is methotrexate, etoposide, and it is oncovin, and it is cyclophosphamide. It is actinomycin D likely. Methotrexate, etoposide, actinomycin D, oncovin, and cyclophosphamide. This is imaco, that is multiple chemotherapeutic drug. It is more toxic, but in high risk cases, we have to prescribe. Is there any place for surgery in case of molar pregnancy? You know, this is the disease. This is the disease where you have already stated that treatment and monitoring is done not on the histopathology but on the beta hCG level. That is called tumor marker. So surgery scope is very, very less. Hysterectomy can be done if the age is more than 40 years. But this does not eliminate the need for monitoring. So still there is chance of metastasis. So hysterectomy is not the solution. Especially hysterectomy is to be done where you have failed to control bleeding. So bleeding could not be controlled. So initially whenever there is bleeding, we give blood and give methotrexate injection. Usually it does respond, but if it does not respond and patient's condition is deteriorating, In that case, we may be resorted to hysterectomy, removal of uterus. Removal of fecal uterine cyst not required. So during hysterectomy, as both the ovaries are cystic, but you need not go for removal of the cyst, because it will automatically, if the molar tissue is removed, then it will automatically undergo regression. Both the ovaries uterine cyst will undergo regression. It does not require surgical treatment, but follow-up is definitely necessary. So that is about the place of surgery. Then what are the other possibilities? Especially where this uh, presentation with the bleeding PV, pain abdomen, and amenorrhea. And so first one is missed abortion. That picture which I have shown to you, that snowstorm appearance, that may be due to missed abortion. Especially if this abortion is associated with hydropic degeneration. There is no chromosomal problem. Only thing, the placental villi undergoes simple degeneration, hydropic degeneration. That means the edema giving rise to the small vesicular space. So by USG picture, it may be confused with the whether you are a missed abortion or we are dealing with a mole. So number one is, in case of mole, beta hCG will be very, very high. And then with the hydropic degeneration, with the missed abortion, the degenerated fibroid, because the presentation is irregular bleeding PV, so degenerated fibroid will give rise to that picture of molar pregnancy by USG. But in this case, if it is a fibroid with fibroid giving rise to irregular bleeding PV, so pregnancy test will be negative or beta hCG will be negative. So that's the way how you can differentiate between degenerated fibroid and the snowstorm appearance of molar pregnancy. So serum beta hCG is low. So here is serum beta hCG low, but here is it is negative. And so on these cases, serum beta hCG will not be high, which occurs with the molar pregnancy or invasive mole. Immunostaining with P57KIP is positive. That I have already mentioned. That is a nucleoprotein derived from the paternal side expressed in presence of maternal gene. So if it is a molar pregnancy, complete mole, it will be negative. But in case of partial mole, and it will be a positive. So, and follow-up not required. So, if it is P57KIP positive, means it is partial mole, so chance of malignancy is very, very less. So, follow-up is not required. Classification. So, here now we can classify the diseases which we have discussed. So, benign is highly deformed mole and partial mole. And malignant is invasive mole, locally invasive, choriocarcinoma, placental site trophoblastic tumor, and endothelial trophoblastic tumor. You see, choriocarcinoma beta hCG is very high, but placental site trophoblastic tumor, cytotrophoblast is much proliferation, endothelial trophoblast is like that. So in all these cases, beta hCG will be high, but not very high like choriocarcinoma. Irrespective of our histopathology, our treatment remaining that methotrexate. The summary is benign disease with 20% chance of malignancy. That is highly deformed mole. Diagnosis and monitoring done by beta hCG level. Not by, and chemotherapy cures the disease. So no other tumor or proliferative disease can be cured by chemotherapy. All the cases we undergo surgery, we suggest surgery, but this is the disease where chemotherapy can cure, not the surgery. Pregnancy allowed after 6 months of normalization of hCG, but not we are mentioning the GTN. So thank you. That is invasive mole. We have already discussed trophoblastic grows in the myometrium, may reach the peritoneum, so metastasis is not there. Respond to, so in this case also, if you find an invasive mole, it will respond to chemotherapy. So, thank you.